Chapter 20, Ankle Joint and Foot. In this chapter, you will need to make sure to know your bones and bony landmarks of the tibia and the fibula, and then of course the foot. When you are palpating the tibia and fibula, make sure I've pulled out some major bony landmarks for not the interosseous membrane, but the medial and lateral malleolus, the crest, the head of the fibula, and then of course the tibial tuberosity, if you will, right through here. And we will palpate that in class. And if you are on an online class, what you will most likely do is go through these, use some maybe some YouTube videos from other PT and PTA schools, or some videos that will give you some highlights and allow you to pause and palpate. As far as the foot goes, you've got the tarsals, the metatarsals, and the phalanges. The tarsals consist of the calcaneus, the talus, the navicular, the cuboid, the first cuneiform, second cuneiform, and third cuneiform. We put navicular tuberosity in there. It's more of the bony landmark of the navicular bone, which you can palpate that on your foot. And then on the other side, what I want you all to notice on the lateral portion of the foot while you're palpating is where the cuboid bone meets the fifth metatarsal. You're going to really find a almost an indention or protrusion, if you will, of the foot. Some are more prominent than others. As far as the calcaneus goes, we're going to go back real quick. I don't have that labeled. Let's see. Let's go forward one more and talk about the metatarsals, and we'll get back to the calcaneus. Metatarsals, these are numbered 1 through 5, medial to lateral. So your most medial section is the first metatarsal. Then you've got the second metatarsal, third metatarsal, fourth metatarsal, and the fifth metatarsal. Fifth will be your most lateral. The first and fifth are weight-bearing bones. Second, third, and fourth, those are not. And you will find, if anyone's ever been at, let's say, a Walgreens or a Walmart over in the health and medical supply section, there's usually a spot where you can stand and actually do an assessment of your feet to determine what type of insole might be good for your foot. And what they're doing on this particular machine, when you stand up, you can see the diagram in front of you, and it's where you personally are bearing the most weight. And those usually show up in a dark color or a red color, if you will, on the machine. And so keep that in mind, that the first and fifth metatarsals are the weight-bearing bones. As far as landmarks go here, the base is the most proximal portion of the metatarsal, and it is concave. And then the head of this bone is considered convex, and it's the distal metatarsal. Phalanges, these are your toes. So your first digit here, first phalange, is considered the great toe. It's your big toe. It has what we call a proximal phalanx and a distal phalanx. The second through fifth phalanges are considered your 4 lesser toes, and each of these, which we will take note later on throughout this chapter as well, is each has 3 sections: proximal, middle, and distal phalanx. So your great toe only has 2 sections, and second through fifth have 3. And then the base, again, of these is concave, and the head is considered convex. As far as functional aspects of the foot, you have the hind foot, which consists of the talus and calcaneus, and that would be your heel. This is what comes in contact first when you are walking, and it influences the direction of the rest of the foot. Then we've got the midfoot, the middle portion. This consists of the navicular, cuboid, and cuneiforms. This is what provides stability and mobility for the foot during gait. And then you've got the forefoot. This is the metatarsals and the phalanges. This is what will adapt to the ground you are walking on. So basically, when we are teaching someone to walk properly, which in a lot of cases it's because they have maybe fractured a hip or a knee, or I'm sorry, fractured a hip or had a knee replacement, or injured something in their lower extremities, and they are having to learn how to walk correctly again. Maybe because they've been using crutches or they've been wearing a boot, whatever the case may be, we really have to encourage our patients to make sure to strike their hind foot first so that it will influence the rest of the foot. Stop and think about, maybe watching someone walk and they're shuffling their feet. Well, they're not striking their heel first. And this is a good foundation for how that person is going to be ambulating. And then, of course, the forefoot, when we talk about adapting to level ground, it's actually they're trying to adapt to whatever ground they are walking on. So that could be gravel, asphalt, it could be the grass, and so on. Joints and motions. So this is a little different than what we had you all learn last year if you took this class last year. For dorsiflexion, your angle of range is going to be from 0 to 20 degrees. Dorsiflexion is when we bring our toes towards the ceiling. Plantar flexion, this is when we point our toes downward. This runs anywhere from 30 to 50 degrees. So you'll start at a neutral position, and when you point your toes downward, 30 to 50 is considered normal range. Inversion, that would be this one right here. If you are going to bring your toe, your great toe, towards the midline of the body, 0 to 5 degrees is roughly the range. Eversion, again, 0 to 5 degrees, and that's when you are pointing the foot outward but keeping the ankle in a steady position. And then adduction and abduction of the foot, basically these primarily occur in the forefoot and accompany inversion and eversion. So when these happen, typically the add and abduction happens. Now when we are measuring these, and you all will learn this in the summertime in the PTA program, we generally don't emphasize a lot of actual measurements with a goniometer on here. You will learn it and you will learn how to do it, but in the clinic you'll find that a lot of our therapists end up eyeballing and doing a compare contrast to see what looks normal, what appears normal. And as long as they've got some range, I'm not usually too worried, but you don't want them to have a lack of range or too much range, and we'll explain why it's a little alarming to have too much range as we get into the diagnoses later on in this PowerPoint. Okay, some more terminology as far as combined motions goes. Supination of the foot is a combination of plantar flexion, inversion, and adduction. So if you want to do that right now, go for it. Go ahead and pause if you need to. Pronation will be the opposite: dorsiflexion, eversion, and abduction. And this is of the foot. Some joints to talk about here. The tibiofibular joint. At a more proximal level, you've got the superior tibiofibular joint, and then distally the inferior tibiofibular joint. The superior tibiofibular joint is a non-axial plane joint. It does have a joint capsule, mainly reinforced by the ligaments. The inferior tibiofibular joint, this is going to have more of a fibrous union, also called syndesmosis. There's no joint capsule down here, and mainly there's just fibrous tissue that's separating the bones and holding the joint together. A lot of the ankle strength will depend on a strong union right here, down at the bottom, at the inferior tibiofibular joint. The talocrural or talotibial joint, we use those interchangeably, or they can be used. This is more of what's considered a tenon and mortise joint. It is a hinge joint. If anyone can remember what a hinge joint is, that's movement in one plane. It is synovial, and then of course uniaxial. It only performs plantar flexion and dorsiflexion here, and make sure you know this for sure. This is considered the true ankle joint. Now you also have the subtalar joint, which is also called the talocalcaneal joint. It consists of the inferior surface of the talus and the superior surface of the calcaneus. It's inseparable from the transverse tarsal joint, and primarily a gliding motion will occur here, and then you've got the motion of inversion and eversion that will occur at this joint, about 5 degrees each again, and make sure you know that the inversion and eversion occur in this joint. The transverse tarsal joint consists of the anterior talus and calcaneus, the posterior navicular and cuboid. There's very little motion here. It provides a combination of movements of pronation and supination. It helps to cause the inversion and eversion that occur in the hindfoot and forefoot. In the foot joint, we saw earlier and went through the bones of the foot. As far as the joints go, you have what's called the metatarsal phalangeal joints, the MTP. Basically what this is the union or the joint between the metatarsal bone and the phalanges. Okay, so the MTPs run in between the metatarsals and the phalanges. Digits 2 through 5 will have a what's called a proximal interphalangeal joint and a distal interphalangeal joint, and that's because there are 3 bones in each of these. Okay, and so you have your PIPs here proximally, and then DIPs distally. In the great toe, all we have is the interphalangeal joint. And you'll need to be familiar with those for lots of reasons, but one in particular is the fact that we do have muscles that will come into union with those specific areas of the foot. As far as the metatarsal phalangeal joints, when we talk about mobility in the great toe, you have the most mobility here, right in through here. Flexion, you've got about 45 degrees, and hyperextension about 90 degrees. So if you put a piece of paper on the ground and you were to try to grip that piece of paper with your bare foot, you would notice that your great toe or your first toe is what will provide, or what should provide, the most mobility. And then of course if you're extending your toes, you will feel most of your mobility is in that main or first toe. And then digits 2 through 5 in those joints, a lot less mobile. As far as the metatarsal phalangeal joint, you only get about 40 degrees of flexion and about 45 degrees of hyperextension. Your point of reference here is going to be your second toe, and what we will see is we will base ab and adduction of the other toes on this second toe or this second joint. You can abduct medially and laterally. You can adduct only as a return from abduction. And the reason we choose the second toe as the reference point is because there's no midline for this particular joint to pass. As far as the interphalangeal joints, digits 2 through 5, the proximal and distal interphalangeal joints, we've discussed that, and then we've discussed the interphalangeal joint, which is only present in the great toe. Make sure you know that. Ligaments and other structures. So we have the ankle joint capsule. This is thin anteriorly and posteriorly. Medially, we've got what's called the deltoid ligament, and then laterally we've got what's called the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. Go ahead and make sure that you are reading about these in your book, but what I have done is pulled out some important information for you all to make sure you know and understand, just for future reference. There are numerous other ligaments that attach at various tarsals and metatarsals, but these are some of the main ones that we want to talk about. As far as the deltoid ligament goes, this is also called the medial collateral ligament. It spreads out into 4 parts, as you can tell. Okay, it strengthens the medial side of the ankle. Very important to know that, and it helps to maintain that medial longitudinal arch. It holds the calcaneus and the navicular against the talus. So these are all important things to know about the deltoid ligament. As far as the lateral ankle ligaments, attachments here, lateral malleolus and the talus and calcaneus, there are 3 parts. We've got the anterior talofibular, the calcaneofibular, and the posterior talofibular. The anterior talofibular, what you probably want to know about that or want to understand, is that it's a very weak ligament. The calcaneofibular, it's long and pretty vertical. Let's see, through here. And then the posterior talofibular is one of your stronger ligaments that you've got to have through here. Provides lateral stability of the ankle. It's most often injured. And if you stop and think about it, these are pretty small ligaments. They've got to be pretty strong and reinforced by other things. If you either naturally have weak ankles or have not strengthened these areas because of maybe a sedentary lifestyle, or maybe it's been injured previously and been in a cast, whatever the case may be, this side is actually what's most often injured. When you walk, we typically will strike with our heel first, as you remember us talking about, and once we place our most distal part of the foot on the ground and we make that connection, injury most often occurs when you are plantar flexed, slightly plantar flexed, and we end up rolling our ankle inward, and it gives away to the lateral stability that we have. So here's where that injury often occurs. If you've ever sprained your ankle or strained it, then you will notice that you probably did it when your foot went inward, not outward. It's a little more uncommon to have a medial ankle sprain. Arches of the foot. The foot must be able to absorb shock adjust to changes in terrain, which would be, whether or not we're on gravel, asphalt, the ground. Think about those mole holes that we might walk on. And then a foot must be able to propel the body forward. Bones of the foot are arranged in arches. Basically, we're standing on a triangle and weight bearing from the base of the calcaneus here, and it runs to the heads of the first and the fifth metatarsals. So here's your triangle or tripod position. We have three arches. We have the medial longitudinal arch on the medial side of the foot, the lateral longitudinal arch on the outside of the foot, and then the transverse arch, which will go across. The medial longitudinal arch serves its purpose on the medial border of the foot, runs from the calcaneus through the talus, navicular, and the three cuneiforms to metatarsals 1 through 3. The talus is the keystone here. It is the top of the arch, and it receives the weight of the body. In normal function of the medial longitudinal arch and the foot, it depresses during weight bearing, and it will recoil when the weight is removed. So if you want to do that right now, let's say you're sitting and your feet are flat on the floor, go ahead and lean forward or come to standing and put some weight on the foot, and you'll notice that the arch will depress or compress. And when you take the weight off, your foot and that arch should recoil like it's supposed to. The lateral longitudinal arch runs from the calcaneus anteriorly through the cuboid to metatarsals 4 and 5. It rests on the ground during weight bearing. The transverse longitudinal arch, this runs from side to side through 3 cuneiforms to the cuboid, and the second cuneiform is the keystone of this particular arch. Okay, so how are the arches maintained? We've got the shape of the bones and their relation to each other, plantar ligaments and aponeurosis, which is also considered fascia, and we'll discuss that here in just a little bit. Basically, no bone is present here, but still great strength is needed in this area. And then, of course, muscles will help maintain the arch. Support structures of the foot, you've got the spring ligament, the long plantar ligament here, the short plantar ligament, and the plantar aponeurosis, or that fascia. And then here's just another picture, bird's eye view. Okay, so the spring ligament attaches to the calcaneus. It runs forward to the navicular. It's short, wide, and most important of the ligaments. It supports the medial side of the longitudinal arch. Make sure you know that. If it's not doing its job correctly, it can cause what's called pes planus, and that basically means that you have a flat foot. Long plantar ligament, this is the longest of the tarsal ligaments. It's more superficial than the spring ligament. It attaches to the calcaneus. It runs forward here to the cuboid and the bases of metatarsals 3 through 5. It supports the lateral longitudinal arch. The short plantar ligament, this is what attaches to the calcaneus and to the cuboid. It helps to support the lateral longitudinal arch. And then the fascia runs from the calcaneus to the proximal phalanges. It helps to support the lateral longitudinal arch, and it acts as a tie rod. Basically, it keeps the posterior from separating from the anterior. Some other support for the arches, also supported by muscles, about 15 to 20%. You've got your inverters and your everters. Medially, the tibialis posterior, the flexor hallucis longus, and the flexor digitorum longus. And laterally, the fibularis longus, formerly known as the peroneus longus muscle. And keep in mind, a lot of these are named for where they are or for what they do. Okay, so we've discussed that in previous chapters, but we will go through in a little more detail. But stop and think about what the action of these muscles are based on their name or where they are located based on their name. Getting into the muscles of the ankle and foot, extrinsic, these will originate on the leg. They're usually found in groups of 3 or combinations of 3, and they're located in 3 anatomical areas. The intrinsic muscles will originate on the tarsal bones. So those are more of your fine motor muscles. And I'm not going to read through all of these. I will have you all just take time to pause through the different muscles. And because we had a few changes in the names of the muscles, some of the muscles, we also had some changes in the nerve, and I may not have corrected all of them. I'll have to look and see. I want to say that so this is changed for sure, the superficial fibular nerve, but I'm looking here and I'm pretty sure that needs to say deep fibular nerve. Check through those in your book, but we will make sure to discuss that in class as well. The stirrup of the foot, fibularis longus muscle on the lateral side and the tibialis anterior muscle on the medial side. So this is what creates or what helps support that arch and create the stirrup looking portion of the foot. Make sure you know this. This is probably a quiz question and probably a test question at some point in time. So, okay. And again, I'm just going through kind of quickly, but you all can make sure to pause if you need to, or look at the actual class notes. We have the same thing in a handout version. Summary of muscle innervation. The tibial nerve, this will be your posterior and plantar surface of the foot. The superficial fibular nerve, lateral side of the leg, and the fibularis, and then deep fibular, which will be the anterior compartment and extensors. And again, more nerve innervations. Something that we wanted to just add on and make sure you all understood. If you've ever stopped and looked at the bottom of your shoe to see where and how it's worn down, we end up doing that every now and then with our patients when they come in and they've got, hip pain, knee pain, foot pain, whatever the case may be. A lot of times I want to look at the bottom of their shoe and see where they've worn down or distributed their weight, and you can actually tell because the soles will look different. It's kind of like a tire on a vehicle. After you've driven it for a while, if it's out of alignment, you'll have more wear on one side. And so when we talk about the calcaneal position, there's what's called a neutral. And if you're looking at someone from the posterior view, everything should be in pretty good alignment through here. When a patient has calcaneal valgus, this is when the distal segment will move away from the midline, okay? So here you've got the distal portion, if you will, right here, and it will move away from the midline. Calcaneal varus is when the distal segment moves toward the midline. And again, this is the posterior view, and the fibular will be on the outside. So this is, you're looking at a right foot. Some common pathologies or diagnoses. We won't get into all of them, but I want to just get you familiar with some before summertime, and you'll have a lot of these in the fall because we'll have to learn what the diagnoses are and how to be able to treat those. So shin splints, we've all probably heard of shin splints before. Those are some what are thought to be micro tears in the periosteum of the bone and little micro tears in the muscle of the shin. And then pes planus, which is the flat foot. Hallux rigidus, we don't talk too much about, and these are all, I think they're in your book. I'm pretty sure they are. Hammer toe, mallet toe, claw toe. I think I've got a few pictures coming up. And then ankle sprain, we discussed a little bit about that. Achilles tendonitis and bone spurs. Pes planus is flat feet. The talar head displaces medially and plantarward. So you'll notice we've got a drop in the arch right here when there's weight bearing, and it almost stays that way even when there's no weight to bear on the foot. Stop and look at your own foot. You may know that you have flat feet already, and we may take a look in class. Hallux valgus, this is lateral deviation of the great toe. In years past, every now and then I'll have a student who is brave enough to show us their hallux valgus. It's never been this extreme at all, but as our patients get older and there's not as much use in the lower extremity, a lot of times these malformations can occur as time goes on, and it's not uncommon to see this in a skilled nursing facility with our older patients. And not everybody will have this, but when the hallux or the great toe deviates, it doesn't give any room for the second phalange to breathe, basically. Claw toe, hammer toe, and mallet toe, different portions of the joint and the toes are either flexed or extended, and as you can tell, when you get in this position, calluses can form from shoes, from the way that you ambulate, and so these can be fixed surgically, but it's up to a foot specialist. And my advice has always been just make sure you get a second opinion, because these are your toes, and these are the key to ambulation and adjusting. Exostosis, bone spurs. This is abnormal bony outgrowth. It's a response to typically overuse or trauma, or some sort of excessive pressure. And you can get bone spurs in other parts of your body, but for now we're talking about the foot area and the ankle area. Common locations: the dorsal tarsometatarsal joint. Let's see. Head of the fifth metatarsal, the calcaneus, the insertion of the plantar fascia, which is very painful, by the way, and then the superior navicular bone. And we'll talk about plantar fasciitis in class. A patient is standing and raises up on the ball of their feet, so the heels of their feet are no longer touching the ground. So they come up on their tiptoes, basically. What motion occurs at the ankle? What muscle performs the motion occurring at the ankle? What's the antagonist or opposite muscle group? What's the effect of gravity? And what muscle is working and what type of contraction is occurring in that muscle? So I've listed your answers. If you are in class with either Chris or I, you will get up and do these scenarios. If you are taking the online class, make sure that you take the time to do these. I know that your instructor will probably have some videos or some extra information to add to these, but the main thing that you want to really understand first and foremost is, not only what motion is occurring, but what's the effect of gravity, because that is really ultimately what changes what muscle is working and why. Patient is sitting in a chair with their feet resting on the floor. The patient lifts their feet up from the floor with the exception of the heel of their foot, which remains on the floor. What motion occurs at the ankle? And then what muscle performs the motion? What's the antagonist? What's the effect of gravity on the above motion? And what muscle is working?